Good evening, everyone, or good afternoon, depending on what part of the state you're in. Thank you for joining me as we continue our ongoing discussions around racial inequality in healthcare. In tonight's session, we're going to be focused on a very important topic, which is how laws impact the care and support that patients receive in underserved communities. Joining me today is our amazing panel. That includes Morgan, Kavisha, and Pooja. Hi, Morgan. Hi, Pooja. Hi, Kavisha. Thank you all for joining me this evening as well. To get us started, I wanted to sort of ask a framing question, which is, before we start to talk about how healthcare policy dictates survival in underserved communities, I think it's actually just important to understand the role of healthcare policy and laws, such as insurance, and how it impacts patient care. So Morgan, I want to start with you. What is the role that policy plays from your perspective?
Well, that's a great opener, Natisha. Thanks and welcome, everybody. It's great to be here. The market for healthcare is not a free market. We have some parts of it are free market, but because most people get their healthcare paid for through some form of insurance, whether it's private insurance or the Medicaid system or the Medicare system, all of those systems have their own rules about what they'll pay for, who can deliver it, all those kinds of things, so the laws and policies that our government puts in place at different levels, federal, state, and sometimes even local, all of that impacts very dramatically the choices that we have. If we think we have choices as consumers, they are constrained by the system that's in place, that's heavily regulated by our government, but also impacted by the private ownership of healthcare assets, like hospitals and doctors' office practices, which in much of the rest of the free world, that's not how we're organized. So that combination of business interests and government direction creates a system where we have some choices, but not all choices.
And Morgan, I think it's actually interesting that you noted that most people have insurance. I think even in that, right, there is a core assumption around care that's really important to unpack, which is that we do have uninsured individuals. And so the fact that there is an insurance policy tied to your care options, and without insurance, I think what your care options are look dramatically different than what your care options are with insurance. Like even that within itself creates a specific dichotomy. And then the types of options within insurance seem very layered. Pooja, I want to turn to you. I saw you nodding a little bit as Morgan speaks. As you think about supporting patients, how does healthcare policy come into play from your perspective?
It kind of depends. You can see it from two sides. It can help or it could hurt patients. And I think that healthcare policy, I'm a part of like AMA, so we've gone to our state legislators, we've gone to Washington, D.C., and just in terms of lobbying, in terms of getting state legislators and different people in government involved in healthcare policy and informed is very important. And a lot of the times, I don't know if they always have the correct information to be making healthcare decisions. And unfortunately, the decisions that they make still impact us as healthcare providers. And I guess I'm not a healthcare provider yet, but I will be in the future. And we kind of have to abide by those laws and restrictions. So it kind of just depends on, so it doesn't necessarily always help patients. It can also hurt them in terms of getting the care that they need.
Kavisha?
So I think healthcare policy is important, much more important than I thought it was when I first started medical school, because I started with this idealistic view of I want to help people, and I think that's why we all go into medicine, but really to make that change for everybody, it needs to start from a policy level. Because as a provider, I feel like you can have an impact on your specific patients, or maybe you can circumvent some rules and try to get that care for special occasions and certain patients. But if it's at a healthcare policy level, then you can actually implement a change that would be helpful to everyone. And it's definitely something that requires more clarity. I think that's the biggest issue that I've noticed both as a future provider, but also a medical care consumer, I'd like to think of myself. So for example, I have 2 insurance plans, and sometimes I'm not able to get medications I need because the 2 insurances are conflicting, and I know how to deal with that, and will call the insurance company or the pharmacy and, try to make that work. But sometimes our patients don't have that options, don't know those things. And so there's a lot of times they just don't receive the medications they need or the care they need just because of an insurance issue that could be fixed, but they really don't know how to work around that.
So there's a few things that came up that I want to touch on. Pooja, I want to circle back to you because one of the things that you noted is a really important distinction between who sets policy versus who actually has the information and the awareness around what the impact of policy. So you made a comment that the policy setters sometimes don't have the information that they need to set the policy thoughtfully. I want to get your take on what are the gaps between the information that providers have versus, or the people directly involved in healthcare have versus the policy setters.
Well, when my team from our school went to DC, we didn't talk to senators themselves, but we talked with their healthcare policy makers, or not makers, but people who handle all that. And one thing that they noted was multiple questions. They had multiple questions regarding what we were talking about, and in terms of just healthcare for all and things like that too. One of the things that they were concerned about was funding, and that's all fair. However, there's multiple aspects where they weren't really informed in terms of, I can't think of a specific example off the top of my head, but I remember a specific instance where they were thinking about different trials and different clinical trials and things like that, and it was not the correct information. And it's just that when people have these healthcare policy makers, they should be informed by people who are actually practicing and actually studying medicine rather than just people that aren't.
Morgan, thank you, Pooja. Morgan, I also want to turn to you because I know this is something that you've had some direct experience with.
Yes, yeah, Pooja raises a great point that our legislators, federal and even to a greater extent at the state level, for the most part, they are not experts, and they have staffers, some of whom are experts, and many are not. I worked in the state capitol for a time in health policy, and I was surprised to learn that the legislators are regular people who have a weird job. I thought they'd be different than us, smarter. They're not. Some of them were incredibly smart. There were some who I have to say didn't seem very smart to me. So they're dependent on their staff members, and they are dependent on lobbyists. And I would give a positive pitch for that, because our legislators cannot possibly do their work without the information that lobbyists bring to them. Yeah, and there are good lobbyists and bad lobbyists. Who are their intentions vary a little bit because they work for a certain agenda, whether it's for doctors or hospitals, other businesses, whatever it is. What's missing from that is patients don't have a lobbyist who's accountable to them directly, and all the healthcare lobbyists will say, and some of them mean it, and some of them just say it. They'll say that what we're proposing is good for patients, and so and sometimes it is, sometimes it isn't. But we couldn't make policy without them, and it was because our legislators are not experts.
So thank you. So when we have these gaps of expertise, I want to circle back to something Kavisha said, but I see Kavisha coming off mute. Kavisha, I'm going to let you chime in, but I also have a question for you. You also brought up that one of the direct impacts of the way that policy, especially when policy is not including the right perspectives, influences individuals, is that the choices that even their doctors can provide to them get limited. So I wanted to hear your perspective a little bit on what are the things that as a provider, it's challenging to navigate without policy change?
Yeah, so kind of touching back to what Pooja and Morgan said, when I think policy is made without healthcare providers' input, it's like when you're sitting far away from things, it sounds like a good plan. And I think people have the best intentions, but then when you actually implement it, or like it's kind of like when you're not in the field itself, it may not make sense. But it's even worse, I think, when you don't have the patient's input, because we're still a step removed as providers. Because, for example, like I said, we'll prescribe something, but then what happens to that prescription? Does the patient actually get it? Are they receiving, we may provide a referral, but are they able to get that appointment? So I think there needs to be actually information from the patient level and provider level that goes into policymaking, not just, our opinion, which we're able to provide somewhat, like we just said with the AMA, and kind of speak with our legislators, but I don't think that patients really have that access to provide their viewpoint, which is important. For example, I used to work at the front desk at UConn Health when COVID happened, and we got this plan of how screening will work and all the new changes at the front desk for visitors and patients. And it seemed great on paper, but when we tried to work with it, it was absolute chaos because they weren't there at the desk making those actual everyday decisions or making that happen. And then to your question that followed, I think for policy change, if it starts with providers, I feel like if there is something in place that's allows them to have more help with patients, they will actually do it. Whereas right now, it's like a one-off special circumstance things. For example, like you need a prior authorization for this, and that's extra work for the provider. And I feel like as providers, we're already so burdened with this charting, that when everything has to be specialized or has extra work, sometimes we defer that or just say, oh, if it's not covered by insurance, it's not. Whereas if there was some type of just universal change in policy to increase that accessibility and make it easier for us to make that accessible to patients, I think we would try harder to make that happen.
Keisha, you just brought up a really important topic that I want to touch on, which is like, what is and isn't covered by insurance, and like what that actually means. Because one of the things that shouldn't be lost here is quality of care can get directly tied to access to quality of insurance. And so therefore, when we talk about where disproportionate impact, I think disproportionate impact starts to show up in communities where access to high quality insurance is not as available, and therefore certain options are not available. Morgan, I know that in terms of healthcare for women, there's a specific example that you've sort of seen and worked through. So I want to turn this question to you to sort of share how options can sometimes have direct impact into options that individuals from communities have.
Sure. Yeah. The circumstance we talked about is one that's of long standing for 40 years or so. We've had in federal law and reenacted time after time that our legislators have voted for this repeatedly. A provision called the Hyde Amendment, which forbids federal funds to be spent on abortions, and the result of that has not been that women can't get abortions. It's that poor women can't get abortions, because that's the part of that's where federal money is spent in healthcare. It doesn't prevent privileged women or wealthy women from getting abortions if they want them, but it makes it much harder for poor women, again, and overrepresented persons of color in that group from getting abortions safely. That's a direct impact, easily measurable.
Kevisha, actually, Pooja, I wanted to also turn to you, because as I was thinking about the intersection between where do these laws actually show up for people, the other component is just like what happens when you go to the doctor, and like, are you able to get the care and support that you need as a person of color, as someone from a socioeconomically struggled background. I know that you've experienced seeing people struggle to get the right care and sort of seeing the cascading effect of that in terms of what options are available to them. So can you share a little bit about the challenges that come up for individuals from underserved communities, and like how that starts to play out as they continue to maybe not even get the right recommendations from the start?
Yeah, so about that, it kind of just depends on who the person is. And we've had multiple lectures on implicit bias and things like that. But if you have a patient that comes in, I guess the experience I had was we had a person of color come in to the ER, and they were just sent back with some medications, and they were just thought of as drug seeking in terms of pain and things like that. I won't say specifics, obviously, but the patient came back a couple weeks later with intense pain, and they ended up having to get surgery because they had a really large complication that the ER doctors just overlooked and said, hey, this person just wants some like drugs. They just are here in order, just based off of, I'm not saying it was just based off of what they look like or anything like that, but I'm just saying that from what we've learned is that people of color more likely are subjected to that kind of thing rather than people who aren't of color, if that makes sense.
Yeah, I think what it says is that we have this intersection of it's already more challenging for individuals of color or communities of color to get the right care they need for various biases that I think everyone here is really committed to unpacking and to getting past and to educating beyond. But then if you sort of also include that every single time you see a doctor, there is a copay. Every single time you get a medication, there's a payment. I think Kavisha brought up, like, yes, we prescribe things. We actually don't know what happens to that prescription. And so every time someone gets care that is not actually the right care that they need, and they get a prescription that doesn't solve their problem, there's sort of this compounding effect of then what is getting covered, what are they being charged? And so the next question I have, and Kavisha, I'll bring this question to you, is one of the things you talked about was just the challenges of navigating the healthcare system for patients. And so what, I guess from your perspective, how does some of those lack of clarity, those challenges and barriers, how does it impact patient trust from underserved communities when it comes to engaging with healthcare providers?
So I think it has a very big impact. And so one of the things I think is, as providers, there's so many time limits. Like even just seeing the patient themselves, it's gone from having a half an hour to 15 minutes to everything. And then providers are trying to chart during that time. So your goal isn't to provide that clarity. So you kind of do what you have to do and rush the patient out, and you send that prescription over, for example. And then the patient gets there, they can't get the prescription, their condition deteriorates, and they end up in the ED, which is a cycle I've seen often during my rotations. And so that's the example I'm going with, but something along those lines usually is what I found happens when we don't provide that clarity. And a lot of it's because we don't have time, or these types of policy constraints and more type of bureaucratic management constraints. But because of that, that patient, I feel like, is not going to return. And like we just said, a lot of times that it ends up being the patient who is a racial minority or from a lower social status. But because of that, because they ended up in the ED, there's that mentality of, well, what was the point of me going to the doctor to begin with? I'll just go to the ED. And we know from research that patients who don't have a primary care doctor and just do ED visits when they need care, or just go to the urgent care, have poor health outcomes in the long run. But I feel like as providers, we set that up when we don't provide that clarity and don't make sure that the care is received when they do approach us initially.
So what I'm hearing from you, Kavisha, is that we actually create a system where preventative care is not a primary focus, and for various reasons, in how underserved communities and underserved individuals receive care and interact with the healthcare system. And if we're not having preventative care, then that's where we start to see things like decreased life outcomes, right? If people are not able to get screening that they need, they're not able to get yearly checkups, if they're not catching issues early, then they're running into issues later down the line. Or even something as small, but like not small, but significant as like whether or not you call the ambulance to get to the hospital. That is a cost that like most people cannot afford out of pocket and could change decisions that individuals make. Morgan, I want to pivot to you because I know that you've seen this from the policy setting side. And so it's interesting to me that on one hand, it seems like it's incredibly expensive for patients to not have ongoing care in a way that feels great to them, and to go to the ER as their healthcare system. And it's bad for patient outcomes. Yet it also seems like there are current policies embedded in systems like Medicare and Medicaid that make it hard for individuals from underserved communities to get access to ongoing care. So where does that disruption come from?
Well, I think Kavisha has part of the answer to that, which is that the emergency department's always open. You can walk in and eventually someone will see you. We're getting an appointment with primary care or an advice nurse or physician assistant, whatever level. And our system is way more complex than physicians. We need to recognize that too, of course. But getting an appointment, those are hoops to get through that an individual who's not adept at navigating for herself or himself will struggle with those steps, just to complete what may seem like simple steps to us, but they're not always simple. And our system now, with most of us, I'd say a little more so in California than other parts of the country, where I am, where almost all of us get our care from a managed care system, understand that the financial bias of the managed care system has tended to be withhold care because it costs to deliver care, and and we all know that has a consequence. It means that then when the care has to be delivered in the emergency room, it's way more expensive, multiples more costly. Nevertheless, the system is only, it moves slowly to do things with a more proactive and preventive perspective. There is movement in that direction, and I'm delighted to see that in California, in the Medicaid system, that we've had many pilot projects, tons of pilot projects, and we're actually moving to roll some of them out on a statewide basis for all of our poor customers. Almost 14 million people get their health care through the Medicaid system in California. And we're rolling out some of these initiatives on a statewide basis where they've only been tested in limited areas before. So there is progress. But this system, it goes back to the point Kavisha raised earlier about navigating through the system, that patients and their families and their immediate caregivers, whether it's someone in the medical office staff or otherwise, have to be prepared to negotiate, advocate, ask for what you want, ask questions, all those things, and some of us are better at that than others. It's a skill that needs to be learned, and some of us need someone else to help us do it. That it may not be in us to do it ourselves. So we need an advocate who will help us do those things.
Thank you, Morgan. We're getting a lot of really good audience questions. There's something that you said that I will definitely circle back to. But I want to pivot us for a second. We have an audience question about healthcare policy, but we're moving it from just the realm of insurance. Because another aspect of healthcare policy, and I'm sure Kavisha and Pooja can think of this, is just like the actual rules that govern what hospitals can and can't do when patients are at the hospital, right? That's another very important component. What is the care that you deserve? How many patients can a nurse and a doctor even have in a rotation? How long can nurses be working for their shifts, right? There are actually lots of other policies that start to influence the care. There was a recent study that came out that someone has noted for us in our audience, so thank you, from the Urban Institute on the differences in patient safety between Black and white patients from the same hospital. Essentially, what the study came to the conclusion is that there are disparities between patient safety outcomes and from from Black and white patients, and that those disparities are even more highlighted when you start to look at where hospitals are located. So the question that we've been asked is, do we have any thoughts on what we can do at a policy level to ensure that folks from different communities get the same quality of care? So I think, Pooja and Kavisha, I would love to hear your thoughts on sort of imagining the future of equitable care. What are some of the policies that we think could be enacted at a hospital level that would help make equitable care more accessible for all patients? And Kavisha, I will start with you.
So this is something that kind of feels close to home. I did a lot of research on maternal mortality and the differences in outcomes between women of color and white women, and it's very eye-opening and evident once you see the research and you see the numbers and you realize that even if you're not doing it intentionally, there are biases, and those biases have far-reaching impacts up to the life of another human being. And I think with healthcare policy-wise, if you're not doing that type of research or you're not exposed to your own biases and education surrounding that, then it's hard to really be aware of it and be mindful of when you're providing care. And so I know with medical students, we've had required courses and biases, or speakers come to talk to us about it. But even that was limited to our first 2 years of medical school. And I think as you progress as a provider, that's very limited and it's not required. So some type of policy around required education, if not research related to healthcare disparities, especially in your own field, so you can see where the issues are and what you can do as a provider on a day-to-day basis to make those changes. But I think it starts with raising awareness. And like I said, sometimes we're so swamped that we don't have that time to do that learning. And so maybe having something like continuing education credits, required education around disparities and your personal biases and what you can do about it.
Sorry, Pooja?
Yeah, I definitely agree with that. I think the first step would be to educate people and give them I guess not classes, but courses in terms of how they can improve in terms of patient care, and being aware of any implicit biases that people have and things like that. Another thing, something that I guess I do as a part of being in the AMA is that we go and talk to legislators, and again, as I already mentioned, talk to them and inform them about the different types of protocols and things like that we have at hospitals. And just in general, having each hospital get its own protocol in terms of what are the steps they do in terms of decreasing maternal mortality, for instance. Maybe I guess consolidating all of the different steps and then making it so that it's a protocol that they have to follow every step or something like that. I mean, that's pretty idealistic. I don't know if that would obviously be possible because each hospital and each state does everything differently, but it's a thought.
I'd also say to our audience who asked this question, and Brian, I also believe that it's awareness. So something that's come up in many of our conversations is just that this level of information that we're starting to get from these studies is not something that most doctors have access to, right? So most doctors do not have a report that shows them, here's the spaces in which there might be inequity gaps in the care that your patients are receiving. And so there is how do we stop the problem at its core? And I do think that there's a question of what can we do to hold hospitals more accountable to receiving the funds that they get based off of equity commitments, that they're going to see improvements and changes and shifts in the outcomes of their patients. And that can also come from an economic standpoint, right? Patients who receive injuries at hospitals are very expensive to take care of, right? So there are lots of different levers that we could potentially consider pulling to help create accountability for improving outcomes for all patients, and to also create levels of data access more regularly that would help to show where those disparities are coming from. I want to pivot to another audience question. We've been using sort of the term underserved communities very broadly. And then as we've been talking, we've been identifying specific communities that come into play, whether that's women of color, people of color. I think another community that can be heavily influenced by healthcare policy, and we're seeing that happen right now, is the LGBTQ community. So for example, there have been some breakthroughs, right, in PrEP being a drug that insurances are covering, which I think has a major positive impact, but there are still some like existing challenges and disparities that negatively influence LGBTQ care. Morgan, I want to pivot to you and ask, what are some of the healthcare policies that exist right now that might, like, that from your perspective, might negatively impact the LGBTQ community?
That's an interesting and a challenging question. I say I'm not expert in that zone, but I'll reflect on a part of that that affects in particular the transgender and intersex community. That our whole system continues to demand a label, male and female. Our system is, and the movement there is very slow. There is movement about that in California and other places to recognize gender is not binary. But our is not just in healthcare. Our entire society is, for the most part, built on that assumption that M and F are the only choices. And plainly, that's not the case. So that's it, and that creates a challenge for anyone in that community to get appropriate care. Of course, and layer on that, it affects all diverse populations of the biases that are some built into the system and some which the people in the system bring to it. The obstacles are they are significant, and they're inherent in that record keeping, basic record keeping that every hospital, every doctor's office does, and that M and F are the choices.
I also think another example, Morgan, that comes to mind for me is just who the insurance holder is. LGBTQ youth are particularly vulnerable in our current system, because if you do not have a family that you are out to, or a family that supports you, but you are currently on their insurance, your options are immediately changed and they're immediately limited. And then I imagine, Pooja and Kavisha, that the options for providers gets limited as well, because a minor might have some say-so in their care, but ultimately your ability to provide care that their parents have not signed off on is likely going to be very limited. So I think that there is sort of a dual system of what does our healthcare cover in terms of medications, gender assignment changes, and then also if you are below the age of 18 and do not have your own insurance, like even the law that you can stay on your parents' insurance until you're 26 or 25 is only as helpful as your parents are, right? So I think if I'm thinking about where the barriers are going to come from for LGBTQ community, it also can just be the ability to make choices, which I know is a theme that came from the start of this conversation. It seems incredibly sentient here, is what are the choices that you have and what is covered, and do you have autonomy to make that choice at the age and time that you need to make those choices? I want to pivot us now to another audience question, which is we're touching on how we build awareness within our curriculum and our educational system. So I think one of the things, Morgan, Pooja, Kavisha, that you've all noted is that healthcare policy is incredibly important, yet there's sort of a triangle of information. There are the policymakers, the practitioners, which includes a large team between nurses, doctors, administrators, and then there is the patient. For doctors and nurses and practitioners to be more informed, it seems like in many cases, individuals have to actually just go out and learn that information on their own. Morgan, from your perspective, what are some of the things that you would like to see done differently so that those working in healthcare have a better understanding of how policy impacts their communities?
That's another great question. Pooja has touched on it, and that is that our medical providers at every level of the system need to understand that the work they're going to do for the people that they're going to serve is is shaped in many ways by policymaking that happens in state legislatures and in Washington, D.C. And so being engaged, our providers need to be engaged in that work of educating, knowing that policymakers are going to affect their work, and being engaged in educating our policymakers about, as Kavisha pointed out, I think, about how this plays out when you try to deliver it in the clinic. And I see that a lot in one of the things that I do in my work is review legislation for how it's going to affect the department I work in, how it will affect our customers, and I'm many steps removed from that too, of course. But that's the mindset that I try to bring to it: is how's this going to be delivered in the street, where it really matters. And I think that's that engagement of our providers with their associations that do that networking in the state capitals and in Washington. It's really important, because that is how the system gets shaped.
Kavisha and Pooja, I imagine that engagement is desired, but maybe challenging to achieve. What does that, what are the changes that we could make in terms of how doctors are educated from your perspective?
I think just from what I've noticed in terms of education and things like that, I think having mandatory seminars and I guess sessions where the providers, not just doctors, but like nurses, nurse practitioners, PAs, everyone should be a part of training that is culturally diverse, and also, I guess, again, includes like implicit bias training, things like that, because the dean of our cultural affairs, actually, she gave us a presentation last year about how implicit bias really impacts the decisions we make as providers. And so just knowing that that is a thing and it exists, I think that also opens the eyes of different providers, and then that makes them question every decision that they make.
I totally agree with what Pooja said. And I think something I didn't mention earlier was the part of the required education that I think we sometimes fail to consider is having it be team-based and have all those different groups learning together in a course. For example, with continuing education credits, sometimes you could just do an online course in your room and just click through a module online and that's it, which I feel kind of defeats the purpose, because it's similar to making policy while sitting 20 feet removed from the actual process that happens. So courses that are required, but also required to be in a team where it's similar to what the environment is like when you're working, whether in a hospital or a clinic with nurses and other practitioners. Even the administrators should be, I feel like, a part of that team, because a lot of times they're the ones that kind of make that final policy decision or make those decisions regarding management steps for the hospital itself. And if they don't really know what's going on or how things are working, not working, then it's hard for them to make those decisions that will benefit both the providers and the patients.
The other thing, Kavisha, that you mentioned earlier that I want to highlight here is also just an understanding that even practitioners are one step removed. And so I think one of the underlying themes here is just sort of increasing equity and diversity as a core foundational goal in all steps of the healthcare system. And so then there's like, how do you also build in more meaningful community outreach and conversation so that communities are telling you what they need and you're developing policy that actually solves the right problems for a community, because there's a lot of different reasons why someone might not be getting care. And maybe the problem is transportation, or maybe the problem is the times that doctor offices are open for them, or maybe the problem is the options that their insurance has for them for their medication. All of those problems require different solutions, and there's not a great way to advocate for the right one without talking to patients.
So I think as you asked that question, it was kind of like you were answering it. You said all these maybes, maybe it's transportation, maybe it's this, and I think it could be a factor of the combination of those things. But the problem is that a lot of us as providers rely on that maybe. For example, when a patient doesn't show up for an appointment, oh, maybe they forgot, maybe they didn't have transportation, but then we forget to take that extra step sometimes, or just don't have the resources to call and say what the issue was and how we can help them solve that issue. And so I think at a basic level, we just need to ask those questions as to how we can improve that access for care, and then develop policy based on that to actually make it be meaningful. For example, right now, I know we have transportation services for people with Medicaid or Medicare, but I've seen patients waiting for 3-4 hours for that one company to come pick them up. And then if they miss them, then they have to wait for another 3-4 hours until, sometimes when I used to work at the desk, I'd see them there till like 8-9 p.m. and their appointments were much earlier in the morning. And so then they spend the entire day at the hospital. And if I was a patient, I personally would not come back to have to be in transport for that long for an appointment that might or might not have been personally meaningful. So I think just asking those questions and getting a direct answer from the people who are being impacted the most on what changes would be helpful, and making sure that they do get that access to care and they continue to want that access to care.
So we're now touching on something that I'm seeing come up from the audience a little bit, which is we know that being educated and aware is a first step. And we know that listening is the first step. But then the next step is action. And I think, Kavisha, you actually just brought up a really good point, which is like, there are actions that happen, but maybe those actions are sometimes missing the core problem. And so one of the big questions I'm seeing in our audience chat is just, what does the next step look like? How do we take everyone being educated and start to build out to better policies and to actual better outcomes? Morgan, I'm going to put this question to you first, because I know that, like, especially in California, there has been some positive progress. And so what does it actually look like to take a first step?
Well, I want to highlight one aspect of that's in place now and is an implementation step. But it's about measurement. I think is where I want to start. I guess is we have to measure the right things, because and then as appropriate, sometimes incentivize accomplishing some of those things. And it's easy to say that. It's really hard. It is really hard to know what to measure and how to incentivize it. But one of the things that exists now at the National Committee for Quality Assurance, which is an accreditation body, is that they have a standards that address population health, which is now one of the labels that's used for this, for an outcomes oriented approach. Let's look at all right, is the community getting healthier or not? And how do we push things in that direction with things like, as Kavisha mentioned, like transportation. And sometimes that transportation to go to an appointment at the doctor's office, no insurance doesn't pay for that. They'll pay for if you have decent insurance, they'll pay for the ambulance to go to the ER, but they won't send a lift to get you to the doctor's office, so you don't have to go to the ER. And the moving to a measurement and assessment of population health is a part of how that can be made better. That it looks at measures that are identified health outcomes, as opposed to procedures and activities, procedures and activities are easier to measure, but they don't connect in the big picture. They don't connect as directly to, is this a healthier community because of the activity of the healthcare system here?
Pooja, as you're looking at your future in medicine, what does this look like in action? So education is the first step. What does implementation look like from your perspective?
I think just going out and actually trying to make a difference in terms of talking to the people who are actually making our laws, educating them, and going out and making a difference. I think that's what that would look like. In the case that I've already mentioned, multiple students from my school, we've had classes and things like that. And then that's how we got informed about the different healthcare biases and things like that. And then we went joined AMA and then were able to actually try and make a difference, although it's a little bit arbitrary in terms of where it goes from there. We try our best to make it so that the laws we pass in AMA go to the House and legislation. But again, it's all a journey and we have to try and figure it out. Sometimes it doesn't actually work that way, but we were, for example, able to write a bill that basically they used to have at detention centers, they used to have the migrants or whoever was at a detention center, they would have DNA collection of those people and then they would put it in a database. And we thought that that was going against human rights. They shouldn't do data collection against people who are, first of all, being held against what they actually want. And we were able to pass it from the AMA level, and then it went to the House and Senate, and then go from there. So it kind of just depends on what they want to do from there.
Yeah, so it seems like there has been, from education, you can start to create communities that then influence direct action. And also, Peter, it's great to hear the work that your group is doing. So thank you for sharing that. It also sounds like beyond that there's continuing to make pushes to create metrics that are measurable, that show meaningful change over time in communities, and how can we sort of start to measure healthcare outcomes and then hold people accountable to improving those outcomes. I think, Morgan, that is something that I've heard from you. I want to pivot to an additional question that has come up, which is, it seems that when we do policy changes, the impact takes resources from one area to give to another area. And I feel that people are reluctant to take away resources because they care about certain issues less. How can we balance these funding distributions and policy changes so advocacy is more convincing to the listeners? So I actually, before we answer that question, I want to maybe start at a different point, which is many times when we're trying to solve problems, we end up in what is, I think, one of the biggest challenges for any DEI work, scarcity mindset, which is that to help one group and to put resources to help one group. So to help LGBTQ youth, it means to focus resources away from Black maternal deaths, right? Like, it almost seems like there can be a challenge of there's so many problems to fix and there's so many different policies, and those policies might benefit one group and hurt another group, that it feels like the balancing act requires you to make choices of which group you care about the most. So actually, I think as I think about this question, maybe one of my questions for this group is, what are steps that we can take to be able to truly be equitable about the way that we advocate for policy change, so that we don't have to feel like we're taking resources from one group and giving to another? Kavisha, I want to start with you and your thoughts of, like, what does an equitable approach to this truly look like from your perspective?
Yeah, so before I answer that, I'd actually like to touch base on your last question and us talk about action and policy change. I think both of what Morgan just said is absolutely true, but I think the next step that I've seen and would like kind of improved upon is, once a policy change has been made, you find that it doesn't work the way you thought it would. And it actually sometimes creates a new problem or has a negative impact. And then instead of making another change or kind of going back on what the initial change was, people just let that ride out or just keep it there because now you've already invested into that idea. And then now you've created another problem that isn't addressed and the first problem still stands. And so I think with policy change and implementing, we should work on taking that step and kind of monitoring our implementation and making sure it is having the effect that we want it to have and not creating additional problems, or even if it has, then address those. And I think the one that comes to mind is opioid addiction and trying to address that. Healthcare providers are now given frequent numbers of how much you're prescribing. And we've had patients at our family medicine clinic come and say, our pain management provider will not provide prescription for pain medication because it creates a ding against them in the system. And we know that with pain management and those types of things, it usually ends up being that racial disparities start playing a huge factor in who gets care and who doesn't. And so I think with metrics, it's something to be careful of the impact that it ends up having, positive versus negative. And then I do not remember what your question was, the second one, so if you could repeat it.
So the question is, how do we navigate moving policy change in a way that is truly equitable? That doesn't feel like in order to solve one problem, we have to pull resources from another problem.
So I think that seems like such a problem that we've created because of the hierarchy and the bureaucratic way that healthcare is starting to feel. If as a country, we spend so much money on healthcare, there's so much funding, but it seems like people's personal agendas take a priority. And that's why, to me, I feel like, oh, putting money into this is taking money away from this. And it's just kind of a mentality of how it's explained and portrayed. Whereas if you tried to look into the budget or policy change wise, all of those issues could be addressed without taking away from one necessarily. But it just seems, I guess, historically and just for patients, it just seems like a fight. And so if I'm not protecting my interests, then I'm giving them up. And so even when there doesn't need to be a fight, there is, and not everything is addressed when it can be.
Morgan.
You have asked the ultimate question. And the simple answer is there is no simple answer. If we can make the pie bigger, then we can do more things. But there are practical limits to what our system is willing to do. Not that, I wouldn't say that what we can do, but what we're willing to do. We're willing to endure a certain amount, some level of taxation, and for publicly funded activities. And even in the private market, we're willing to pay something for health insurance, but it's not unlimited. And so we wind up, we do, I don't want to sound too downbeat or cynical about it, but it is, the pie is some size, and changing the size of the pie can be done, but it's not limitless. But one of the things that we're really not very good at is getting rid of things that don't work very well. And Kavisha touched on this, that we put in programs, and in the government, we struggle with that a lot, because we still will spend money on a pilot project, and if it doesn't go very well, it may not get abolished. And if it didn't produce the desired results on a population level, it should be eliminated. Put those resources in something else that works better. But part of what happens, the way our system works, is that someone may still be benefited by that pilot program, or believes that they're benefited by it, and so they advocate to keep it, to not abolish it, and so we don't abolish it, and we layer something else on top of it, and it's really messy and not very efficient. But I will say, be grateful you don't get all the government you pay for. That would be worse. But how to do this, how to apply resources where they're needed without shortchanging other areas is a super difficult question. They are hard choices.
Pooja, your thoughts?
I definitely agree with what Kavisha and Morgan said. I think it's very difficult to say this one thing is more important than this, so we should take money away from this specific thing and then put it towards that. I just think that it's a mentality in terms of, oh, I think this is more important, so I think we should support this. I'm not going to support certain other things. And I think that it's a very challenging topic. Again, as Morgan mentioned, if we could make the pie bigger, then that'd be great. But I think it's just difficult to redistribute specific things and get rid of funding for other things.
I'd also posit that the theory of sort of universal design has a lot of value here, which is that, like, in many cases, making something better for our most vulnerable communities doesn't actually make it worse for privileged communities. And so like considering, Morgan, you brought up gender identification. Having forms that have more options for gender identification doesn't hurt people who identify as male or female, but it does help people who need options, right? And so I do think one of the ways that you can redistribute the pie without actually, and granted, this takes lobbying, right? Because like to Kavisha's point, there's bureaucracy and there is politics sometimes surrounding these things. But the truth is, the practices that are going to help a Black mother come out of a hospital maternity ward healthy aren't going to hurt a white mother who also needs to come out of that maternity ward healthy. And so I do think that there is a shift of who is the patient that we're imagining when we're creating a policy, when we're creating a process and a procedure. If we actually imagined our most vulnerable patient and started there, could we actually just build something that works for everyone more broadly in a way that's really engaging? We are coming to the end of our time. I know our amazing TA Kristen made a note of that in chat. And so I'm going to ask us one final question around the horn. And this question has come up. And so I want to end us sort of thinking about what policy that works looks like, right? We've been talking a lot about where the gaps are. We've been talking a lot about where the challenges are. I think those are incredibly important. But the other thing is that we shouldn't walk away from this conversation feeling like the system is broken. So what do we do? In fact, there are lots of spaces in which, like, when policy is done right, people get access to things that they would not normally have access to. People can afford an ambulance ride. People can afford to get access to the PrEP drug. And so we know that when policy is used effectively and when practitioners work with communities, it can make a huge difference. The question from our audience is, are there models of true community interprofessional care that are working? If you cannot think of a model that works, then I would like you to think about what it would look like if it did. Like, what is your vision of a system in which policy, providers, and patients are working together in a way that produces better outcomes? Pooja, I'm going to start with you.
I think a great way to think about that, I can't think of a specific one, but for instance, if we're talking about our communities and what resources we have and things like that, I know that hospitals can work together with each other. For instance, our hospital is a bigger, larger tertiary center. If community hospitals don't actually have the resources, the capabilities of handling certain instances, they should immediately make transportation to larger tertiary centers and then work together with that care team to make a difference for the patient's outcomes. So I think that that's a great way to think about everything working together.
Morgan.
Let me see. Okay, I look like I might be having some technical difficulties there. Hopefully I'm still in here somewhere. Well, in my state, we have we've done a lot of work, and we're a big state. We have a incredible range of types of systems, urban and rural, and everything in between. Where we're moving is a more, we are indeed moving to a much more holistic approach. We've had some long-term pilot care, it's called whole person care, where we moved to, I think population health is a good name for it now, where a more holistic view of the patient is taken by the system, where you have a team of professionals working together, and the team is expanding beyond traditional healthcare to include housing and food and other social services that contribute to a healthier community, and look at a patient from a much more rounded perspective. And we're making a big investment in that in California for our Medicaid population, because the pilots have been reasonably successful. They're not perfect. It's very difficult. Part of it, and part of that is engaging patients, because many of the patients who need the help the most are not are not able to negotiate for themselves very well. Sometimes they're even uncooperative. So it's a challenge in many ways, but there is progress being made, and I think it's that more holistic view where the providers come around the table and really do have that patient at the center of their interest and intention.
And I think that progress is important, Morgan, because that's what starts to build trust, and that's what starts to build education, and that's what allows patients to start to engage and to be willing and trusting to engage. And last, but definitely not least, Kavisha.
So in the interest of time and being concise, I think earlier you said that we're kind of like a triangle with the patient, provider, and policy. And so I think ideally, we need to shift from that to like a Venn diagram with 3 circles so that we're all kind of overlapping and seeing each other's side, but then also have our own independent roles. And so I think that's my take on that.
Awesome. I want to thank Morgan, Pooja, and Kavisha for joining me this evening and having this discussion. I also want to thank the audience. I saw a lot of amazing conversation, sharing ideas and chats. The only way that this continues to move in the direction that we want to is what Pooja talked about. It's people getting involved, writing legislator, doing the education. It's what Morgan talked about in terms of everyone, practitioners better understanding how laws influence the outcomes of their patients and using that information to make better recommendations. It's what Kavisha talked about in terms of building that Venn diagram where we see everyone's perspectives and have the patient at the center of our solutions. I'm walking away from today with a lot of great ideas in terms of ways that we can educate ourselves, but then take that education and move it into action. And so I want to thank each and every one of you for joining me this evening, and I hope that we see you in August when we have our next session. Thank you and have a great night.